Hello, I'm Lisa Martin from HORIBA Veterinary, part of HORIBA Healthcare, and I'm delighted to welcome you all to this continuing professional development webinar, the next in our ongoing series. We're very pleased to have you join us today. All of our previous CPD content on a wide range of veterinary subjects is available to watch back free of charge at any time in the support section of the HORIBA Veterinary website. Firstly, I'd like to provide an introduction to our speaker, tell you what to expect from the webinar and a little bit about HORIBA. We're very pleased to be working today with Ian Wright, practicing veterinary surgeon and co-owner of the Mount Veterinary Practice in Fleetwood, Lancashire. He'll be speaking on and answering your questions today on an update on the changing face of parasite infections and distribution across the UK and Europe and what this means for pets, livestock and the people that work with and care for them. Ian has a master's degree in veterinary parasitology, is the current chair of the European Scientific Council of Companion Animal Parasites and is editorial board member for the Companion Animal Journal. Ian has over 130 published peer-reviewed articles and papers and peer reviews for a variety of journals. He continues to carry out research in practice, including work on intestinal nematodes and tick-borne diseases. HORIBA Veterinary sits within HORIBA UK with expertise in many areas of scientific testing, including fluorescence and particle characterisation, automotive emissions and energy, small and large-scale air and water quality testing. As a well-established provider of laboratory diagnostic instruments and consumables with our own local technical support, we work with medical and veterinary reference laboratories, academia, general practice and specialist settings. Our product range currently includes handheld meters running single parameter tests, high-capacity, user-friendly automated instruments, nucleic acid extraction, and the first fully integrated in-house PCR testing system. Here's a brief introduction. Our Laqua Twin handheld meters work in seconds on small sample volumes for individual parameters, including ionised calcium, pH and electrolytes, and all can be used patient-side. HORIBA supply and support benchtop systems for clinical chemistry testing from occasional use to specialist, large reference laboratory throughput with the benefit of a small sample volume requirement. These offer highly cost-effective solutions and bespoke profiles for esoteric and project testing. Our range also includes instruments for immunoassay and blood gas analysis. The HORIBA Pocket Central PCR Analyzer is a unique, easy-to-use benchtop system which integrates seamlessly with any current lab provision. Within reach of all veterinary settings, each step of the full PCR process is fully automated and can be run by any trained member of the practice team 24 hours a day. Up to 8 samples are processed simultaneously with results available in just 85 minutes. Speeding up diagnosis times, informing case management and prescribing decisions, including the responsible use of medicines. The HORIBA Pocket Central test range includes over 190 assays in total, enabling fast and easy testing for common and exotic bacteria, viruses, parasites and protozoa across not just small animal, but equine, farm, poultry, aquaculture and biosecurity or environmental work. Very easy and reliable PCR testing for all species is now accessible to everyone. Should you have any questions, please write your query into the box on the screen and we will cover as much as possible at the end of the webinar. If you're watching live and would like HORIBA to issue you with a CPD certificate of attendance, please provide your name and email address in the chat box and we'll send it on in the coming days. You'll also have our contact details at the end of the webinar if there are any further queries or if you're watching back. The event recording will shortly be available to view via the HORIBA Veterinary website and you'll be sent details to enable access for you or any interested colleagues. So now I'd like to hand over to Ian for his presentation on new exotic parasites. Are they worming their way in?
Here we are, and we're going to be talking about new exotic parasites, specifically with cats and dogs. My livestock's a bit rusty these days, unless they're an intermediate host and they're going to get eaten, then I'm a little bit patchy. But cats and dogs, we're good to go. And we're still seeing in the UK many different types of exotic parasite in infected pets coming into the country, but also for the potential for exotic parasites to be introduced in other ways. A changing climate, changing habitats across Europe, increases in wildlife reservoirs are all making it likely that while these movements continue to occur, that sooner or later new parasites in new vectors are going to establish, and they're going to be part of our day-to-day lives in practice. So we're going to consider a few of the parasites that I think we're seeing more and more frequently, and the likelihood of their establishment and how we might try and prevent that with our individual patients. So when we're worrying about different parasites establishing in the UK, there's a number of different ways that that might happen. So first of all, we may have the introduction of novel parasites into vectors that we already have. So a good example of that would be Dirofilaria repens. Now, this is a phylloid worm that isn't currently endemic in the UK, but the mosquitoes that transmit it are present right across the country. So if enough dogs come into the UK that are infected, it would only be a matter of time if they were left untreated before Dirofilaria repens established in our own mosquito vectors. We might have them come in wholesale. So Rhiphocephalus ticks are often seen on travelled or imported dogs, less commonly in cats, but we do see them on cats, and they can transmit a wide range of tick-borne pathogens. So although they're not endemic in the UK, they might arrive with those tick-borne pathogens, might temporarily establish in people's homes, transmission might take place as an entire unit without the vector or the pathogen establishing in the wider UK. We have parasites like Phalasia calopeda, which is an eyeworm I'm going to talk about a little bit later, produces great photos, which is following its fruit fly vector around. So the fruit fly is gradually becoming established in the UK, in different parts of Europe. Once it's established, then as infected dogs get moved around with the parasite, the vector gets exposed and the two spread in step as the climate favours the spread of the fruit fly. And then finally, many of us see lots and lots of leishmania now in practice, which is remarkable given that leishmania still isn't endemic in the UK, but it's simply due to the large numbers of infected dogs mostly that are brought into the UK, and that just increases our likelihood of seeing it. So although we don't have the sandfly vector that transmits it, there are non-vector routes of transmission, which we'll talk about, but the likelihood is that you're going to see cases needs to be on your differential list, even though the parasite isn't currently endemic. So in terms of coming into the UK, we tend to think of, because of the situation in which we work, we tend to think of pets coming into the UK, either having travelled or being permanently relocated. And that is an area that we're going to focus on because, as well as it being our focus, it is a major route of new parasites coming into the UK. We mustn't forget, though, there are other important routes. So across Europe, transport hosts, so deer have been very good at moving ticks with their pathogens right across Europe, causing rapid spread of, say, tick-borne encephalitis virus as an example. but also migratory birds. Deer are fairly limited when it comes to water crossing, but migratory birds, if they get to a sea or an ocean, can move ticks across those spaces. And we think that's already happened with tick-borne encephalitis virus in the UK. Certainly arrived, the migratory birds are a top suspect as to how it might have got in. As people, we're very good at accidentally moving vectors around, so we might trap insects in our vehicles or in our luggage. Ticks might get onto us, but they might also get into our clothes. We might move them around as part of a travelling group, part of a travelling package, without actually realising that we're moving them or that we've been exposed. So all of these routes are important, but there is no doubt that one of the major drivers for new parasites in companion animals, some of them with zoonotic potential, is the movement and the permanent relocation of pets, mostly dogs. So when we have these lovely dogs that are often in new homes, excited new owners, very happy that they've rescued a pet, that they've brought it into the UK, sometimes perhaps slightly at odds with the own way that we view it as veterinary professionals, but a very rewarding experience for many people. But we have to manage, we are the first sort of screening line of defence against any pathogens that they might be carrying. So when we're assessing and we're reviewing dogs that have come in, and cats for the first time, that have got this travel history, one of the main aims that we're trying to achieve is to prevent novel parasite establishment here. But there are also very personal reasons that owners might care, might want to spend money, might want to invest in getting parasites in these individual pets under control. I mean, in some cases, it's going to be protecting them and also the wider public from zoonotic risk. But in many cases, it's simply going to be so we can health plan for the individual patient. Many of the parasites that we're going to talk about, heartworm, Ehrlichia, Brucella, Leishmania, all have long incubation periods of months, sometimes years. So if we can identify infected dogs, it means we can either try and eliminate or manage those parasites before they do too much damage to that individual patient. So when, let's say when that dog lands on your consulting room table, which are the parasites that you would be really concerned about? Well, you'd be concerned about fly-borne nematodes, so heartworm, skin, filaroid nematodes like Dirofilaria repens, Phalasia calopeda, eyeworm. We're very concerned about tick-borne pathogens, of which there is a large range that I'm going to touch upon. Leishmania infantum is a big one, and I mean a huge one in terms of future health for that individual patient. And the headline grabbing, not really a parasite, but I'm going to talk about it briefly anyway, Brucella canis, largely feared because of its zoonotic risk, but also potential economic hits with breeding issues. So let's start with what feels like an old friend, Dirofilaria immitis. Something that's been on European radars for a very long time. It's mosquito-transmitted worm. I mean, the worms, for those of you who still aren't familiar, about 10 centimetres long, living in the heart chambers, pulmonary artery, can cause very significant disease in dogs, cats, and ferrets. Although often in cats, the disease is respiratory. It's associated with inflammatory reactions, migrating larvae. The mosquitoes that transmit them are present right across Europe, but it's been traditionally a southern European parasite, seasonally Eastern European parasite, simply because temperature limits its life cycle. It needs minimum temperatures to be able to establish in a country and be transmitted. The difficulty, though, is that as lots of infected dogs get moved around, the temperature increase that we're seeing across Europe, so climate change, is making more and more areas accessible. And this is causing its very definite trackable spread north, east, across Europe. So becoming more consistently endemic in many Eastern European countries, but that southern tide line is moving north as well, up into sort of mid-France. Certain Central European countries are going to be at increasing risk. At the moment, it's nowhere near warm enough in the UK, but it's getting warmer. So more and more as I give these talks, I continue to emphasize that Dirofilaria immitis is of most concern to the individual patient that's carrying it. There is a slowly climbing risk that over the next few years it could establish endemic foci here, perhaps in the south of England. So it is just something that we have to bear in mind. We have to bear it in mind because there are more and more infected dogs coming into the UK with the parasite. At ESCAT nationally, we log the queries that we get and the case queries that we get, and Dirofilaria immitis has remained consistently high in terms of the number of queries that we get each quarter, and a lot of them are fresh cases. So although this isn't sort of peer-reviewed publications, it's evidence that infected dogs are continuing to come in. I think that's probably the experience of most of us in day-to-day practice. Typically see these signs of cardiopulmonary disease, so it's important that we diagnose cases early, that we jump on those signs, but also that we screen imported dogs, that we can identify positive animals so we can treat them. So if we catch cases early, if we catch cases before heart disease particularly progresses, then prognostic outcomes are so much better for those individually infected dogs. But it will start to play a more and more important role as the risk of establishment in the UK increases. And as has always been the case, monthly macrocyclic lactone treatment is essential for pets, so dogs, cats and ferrets that are travelling to endemic countries. So this is ESCAP's latest map showing sort of distribution of heartworm and also Dirofilaria repens. And it's really just to demonstrate the difference between the two. So the hash lines are Dirofilaria repens, which is free, doesn't need the temperature restrictions that Dirofilaria immitis needs. But even with those temperature restrictions, we can see that it's crept north. Many of the countries that are now green, I wouldn't necessarily classify as southern Europe. It is just very gradually, steadily moving north. So we can't be complacent. So diagnosis for heartworm is really important. It's important that we get in there early. So we want a nice, highly sensitive and specific test. There's a number of ways that we could go. So we could examine the blood directly. We could look for microfilarial worms in the bloodstream. If you're really lucky, you might catch one with a direct smear, but that would be a very low sensitivity approach. If you get a capillary tube, spin it down, sort of hematocrit style, you can see active worms. We won't know if they're heartworm without breaking it, putting it on a slide and staining it, but you'll be able to see active microfilaria there. The most effective direct examination technique is the Knott's test, which is a concentration technique. So mix the blood with formalin, which helps to break down a lot of the debris and cells. You spin it down, and then you take the little bit at the bottom, resuspend it on a slide, stain it, and then you can have a look for microfilaria, whether they be from heartworm, Dirofilaria repens, or other microfilarial parasites. So it's a good catch-all. It's very easy to do. Some external labs do it. If anybody's interested, I can supply them with a protocol. It's very, very straightforward to do. But it is, I guess, it's a little bit more labour intensive than, say, doing a blood antigen test, which I'll come to in a moment. Ultrasound, if you've got a skilled ultrasonographer, then that is really useful. So, because you can identify the actual worms, you can count them, get a feel for how many adult worms are present, because that, if you've got a lot of worms, may potentially affect your prognosis. You do need someone who's skilled. They've got to follow the pulmonary artery to the bifurcation to be sure. And if there's very low burdens, very easy to miss worms. But otherwise, they are visible. Their walls show up nicely on ultrasound, and you can pick them up once you've got your eye in with a little bit of practice. Far and away, the most common technique that's used is blood antigen testing. So this is looking for antigen serology in the blood that comes mostly from uterine secretions. So this is a test which is, under most circumstances, highly sensitive, very specific, which makes it an excellent screening test. The only thing that we have to be aware of is that it does rely on worms to be present and in reasonable numbers for it to get really high sensitivity. So female worms just really knock that sensitivity up. So the more worms you've got, the better your chances. If you've got a female worm in there, it goes straight up. Cats often either don't have an adult worm or they'll just have one or two. So sensitivity of this technique is much lower in cats. If we're going to do a diagnostic test for heartworm, rather than treat presumptively, tends to be antibody serology rather than antigen. But it is a great test for screening dogs. In endemic countries, they'll sometimes heat treat the serum first because that increases sensitivity of the test, but it also decreases specificity. So, in those circumstances, you've got a position where it starts to lose its value then as a very definite screen. You can't be as confident with a positive result as you were before. There are lots of patient-side antigen tests. This one on the right is just one example to give you a flavour, but it means that it can be run quickly. You can also do PCR is another sort of reasonably sensitive, specific test. It tends to be the patient-side manner of these tests and very high specificity that's made them very popular. Dirofilaria repens is mosquito transmitted as well, but as I've described, it doesn't have that temperature restriction keeping it out. You have adults very similar to Dirofilaria immitis, but they're living either diffusely in the skin or in skin nodules. So if I had the choice of having a 10 centimetre worm, rather have it in the skin than have it in my heart or pulmonary artery. And as a result, pathogenicity in dogs and less commonly cats tends to be much, much lower. So you might get some dermatological signs, you might get ocular signs if they lodge in and around the eye, but generally very, very well tolerated. The main reason that we're concerned about it is its zoonotic potential. So if you're living in an endemic country and you're fed upon by infected mosquitoes, you too could get fascinating skin lesions like this, and that makes its presence in your country undesirable. Now, great swathes of Europe are now infected, but we do have the opportunity, at least for a time, to keep it out. Essentially, whether it's going to establish is an odds game of how many infected dogs come in and how quickly it is before they're identified and treated. And that is tricky because a lot of them are subclinical. We've had a few UK cases recorded in peer review literature, but that is going to be a massive underestimate of the total. I mean, I have a lot of people contact me either through SGAP or individually to discuss Dirofilaria repens cases, or to let me know that they've seen one, and they're generally not reported. I'll come to that in a moment, but you know, it's going to be a massive underestimate. What we're seeing officially is just going to be the tip of the iceberg. So control, again, is based on licensed macrocyclic lactones monthly while pets are travelling abroad, so they're not exposed. But also we just want to be aware of relevant clinical signs in dogs entering the country, because they may need treating clinically as well as for biosecurity purposes. So you're looking for dermatitis, skin swellings or nodules, ocular signs. Many cases are subclinical, so we can't just rely on those clinical signs picking up infected dogs. So in dogs, I would either consider doing a modified NOTS, which I mean is useful for heartworm as well, or if they've tested heartworm antigen negative, I would maybe just give them a preventative treatment dose, either moxidectin, milbemycin, and that is very likely to kill any worms that they've got on board. Sometimes they form nodules that are quite large. Under those circumstances, for that patient, you might want to surgically remove them. And this is just the map again, just to emphasise how close it is. I mean, it's north of France, just across the water from us, but all of those countries that you can see with hashed lines, we frequently get imported rescue dogs from. Thalassia calopeda is a slightly different animal. The oriental eyeworm infects a wide range of mammals, not just sort of canids and sort of carnivores like cats or muscelids, but herbivorous mammals like rabbits as well, can infect humans and does do regularly. And it relies on its transmission for the humble fruit fly, Fortica species. And it gets transmitted because, as well as fruit and lovely tree sap, Fortica likes feeding on tear secretions, so it will move the worm from one eye to another. This transmission is reliant on Fortica, but it is still spread very rapidly across Europe. And the reason for that is that the fruit fly is loving our changes in habitat, so the increased forestation that's occurring across Europe, but also the climate. So it loves that warming, slightly more humid, hotter climate, and that has really facilitated its spread. We have the vector present currently in pockets in the south of England, but as the temperature warms, we're likely to see that increasingly spread through the UK. And again, that increases the chances of us getting a hit. So an infected dog that's been imported or travelled, come into contact with the fruit fly, and then you have the risk of establishment. And again, there are cases that have been reported in the literature, but just like repens, that is going to be a massive underestimate of the total. So it's like a cocktail of risk that's been mixed together perfectly. You've got the spread of the vector, but the spread of the vector is happening just at a time when more and more dogs are travelling and being permanently relocated, not just in the UK, but right across Europe. So control is a very similar message in that you want to diagnose these cases early so you can treat and kill that worm, and then it can't be exposed to those lovely, poor, innocent fruit flies. Treatment is crucial, rapid identification for that reason, but also, again, to improve prognostic outcome for the eye that they're infected. So caught early, these worms may be tolerated or cause conjunctivitis. Allowed to just sit in the eye, that's going to progress to keratitis, ulcers, and ultimately potentially blindness. So we don't want to let this parasite run and run for the patient either. We want to recognise it's there and get it treated. So where we're looking for them, it's physical identification in this case. You're looking for them in the conjunctival sac. You may be able to see them. If you're really lucky, you might just see them. You might need a little bit of local anaesthetic, possibly even sedation, so you can have a good rummage around. But then, you too could have wonderful pictures like this of Phalasia eyeworms wandering across those eyes. And then, you want to subsequently treat with a licensed product. So you treat with macrocyclic lactone, but you also want to flush and physically remove those worms from the eye, because if you get rid of the worms quickly, the eye is going to feel a lot better for starters. So using a combination of those two things to bring the situation under control. I should say that although all of these parasites that I've just discussed so far are zoonotic, they're zoonotic through their vectors. So if owners panic, if they don't share my, excitement at having worms crawling across eyes or in skin, they don't need to panic. There's no direct zoonotic risk. They would have to infect a vector and then a vector infect people. So it's a two-step process. Linguatula serrata is another wonderful parasite. It's a little bit of an oddity. I always lump it in with worms and worm-like parasites. It's not really a worm. It's a pentastomid, so more akin to shrimps, really, sort of crustacean-like organism. About 2 to 3 centimetres long. They live in the nasal cavities and the upper airways, mostly of canids. So, sort of dogs mostly, the occasional cat gets infected. Very, very commonly endemic in European, Eastern European and Middle Eastern countries. But again, we're seeing them turn up in many other countries as dogs are relocated from those regions. Generally, again, well tolerated by infected dogs, might cause some reverse sneezing, gagging, epistaxis, sometimes completely subclinical. The first thing that anybody knows is when something that looks like an extra from Alien gets sneezed up on the carpet or on the kitchen floor, and then the owners get on the big red phone to that local vet to find out what's going on. It was often the first sign that anyone sees. There have been a number actually of reported cases in the literature. Again, very likely an underestimate, but there have been a goodly number now that have been recorded. Interestingly, very recently, one in an untravelled pet. Now that was unexpected. There have been odd cases in wildlife over the decades reported in the UK, but it isn't thought to be endemic, widespread, maybe sort of tiny foci, but not widespread. So it was unclear whether this pet had acquired the parasite in the UK or whether it had acquired it through something that had been imported. It was eating imported dog food from, I believe, off the top of my head, from Central Europe. So we think perhaps somewhere along the food chain, an intermediate host got in, and then the dog ate the food and was subsequently infected. So that is what we're working on as a theory. So this isn't a vector transmitted parasite. This is a parasite that needs an intermediate host. So things like livestock mostly, lagomorphs, rabbits sometimes are infected. There's occasional wildlife reservoirs. The dogs eat the intermediate host, then they get infected and they get the adult parasites in their nasal cavities, upper airways. We can get infected in one of two ways. So we can get infected by eating raw offal. If you're like out in the Middle East, living the dream, shoveling that raw offal down you, yeah, there are spectacular acute anaphylactic reactions that can happen from getting the parasite, the adult parasite, in your own nasal cavity or airway. However, in the UK, we're much more likely to get infected by contact with infected dogs, and then we would act as an intermediate host. So we would get the sort of nymphs, proto-nymphs in our bodies. Zoonotic infection is uncommon. When it does happen, it's rarely serious, but there are some great cases in the literature where people have accidentally consumed eggs from nasal secretions or occasionally in feces from pets, and they've ended up with shrimp-like organisms swimming around their eye, or they've ended up with lesions in their liver. So low risk, but not zero, not to be taken lightly. So good hand hygiene if you've got infected pets is really important, and crucially, no facial snuggling. That's kind of a rule for life for me with dogs, really, but some people love to facial snuggling. If you have a linguatula serrata, please stop until the infection's eliminated. And same story, early diagnosis is essential to try and prevent establishment of endemic foci. Some cases are self-limiting, but I bet the dog's going to feel better if it hasn't got 2 to 3 centimetre parasite stuck in its nasopharynx. But it will also limit that immediate zoonotic exposure risk to people who are in contact with the dog. There are only, frustratingly, for such a common parasite, there are only a few case reports in the literature. They are gradually increasing, but still not a huge body of work to say what is a useful treatment and how long and how frequently to treat for. The best we've got is that macrocyclic lactones appear to be effective, so moxidectin, milbemycin. I believe there's a written up case now with selamectin. So you can just treat with those. It's useful to scope the nasopharynx if you can to see what parasites are there. So then you can treat. You can rescope and see if treatment's been effective. If that's not affordable or practical, just keep going with your macrocyclic lactone treatments at a licensed frequency, and there's not license for linguatula, but a licensed frequency for other parasites, and you're probably going to be okay, I think is the best we can say. Part of the problem that we're having as parasites and epidemiologists, even as vets looking for information in practice, is that so many of these cases are seen but not recorded. So we don't know how many there are. We don't know if there are sort of foci, sort of clusters of cases. We don't know if transmission is occurring within the UK. So I would implore you that if you do get either linguatula serrata or suspected diarrheofilaria repens or filaria, please don't throw them away. I was just saying before we went on air that I can understand if people were, keeping these lovely parasites for themselves instead of sending them away, but they're just throwing them away, which, makes my heart ache. So please send them to the APHA. They have a completely free identification scheme. They'll confirm the parasite for you, but also it will be logged so we can start to get an epidemiological picture of how many of these parasites are coming into the UK and whether there is a risk of transmission already taking place. Let's move on to ticks, to the wonderful world of ticks. We see lots of ticks coming in imported dogs and cats, mostly dogs, and they tend to be mostly, not completely, we have had the odd curveball, but they're mostly either Rhiphocephalus, Dermacentor or Ixodes. Rhiphocephalus, not endemic in the UK, but we see a lot attached to dogs coming into the country, either from Europe or Asia, Africa, North and South America. Rhiphocephalus is endemic in all of these countries. And it can transmit a wide range of pathogens. So Ehrlichia, Hepatozoon, Anaplasma, Babesia vogeli are all pathogenic to dogs, and significant pathogens. Rickettsia canorii, which is Mediterranean spotted fever, is a significant zoonosis, and that's present where rhiphocephalus is across southern Eastern Europe. So, an important zoonosis, which if rhiphocephalus establishes in people's homes, means that you can potentially get zoonotic exposure. Dermacenta is more monogamous. It's associated with Babesia canis transmission, is the pathogen that we're really worried about in dogs. No zoonotic potential there. And Ixodes, as well as transmitting Lyme across the whole of Europe, also transmits a new pathogen that we're worried about, tick-borne encephalitis virus. So if we start with tick-borne encephalitis virus, this is a pathogen that causes, perhaps unsurprisingly, tick-borne encephalitis. So this is a nasty virus, zoonotic, but like almost all tick-borne pathogens, not a direct risk to us from infected dogs. So if we have an infected dog, we don't need to panic. But it's transmitted through infected ticks. So once it becomes endemic in a country, the risk of human exposure starts to go up. It is a significant zoonosis. So, 1 to 2% mortality rate, significant neurological signs in 10 to 20% of cases. It's something that you don't want. And it's another very good reason for sensible tick prevention measures in yourselves if you're going out into the countryside and living the dream, taking those sort of sensible basic precautions. It's increasingly endemic across the whole of Europe. So like a lot of the parasites that we're talking about, it was sitting in Eastern Europe and in Asia, and then it's had a big push, driven in this case, not really by pet movements, but mostly wide-ranging movements of ticks hitching a lift on deer and birds. Dogs are affected much less frequently than humans, we think, but it has a very high fatality rate if they develop clinical disease. So it is something that we need to have on our radar. So we were free of tick-borne encephalitis virus for a long time, but it had a sort of feeling of inevitability about it, with it rampaging across the UK, across Europe, sorry, that it was going to arrive in the UK sooner or later. And it has. So there have been 21 human cases confirmed in the UK between 2015 and 2024, so sort of over the last 10 years. Only 3 of those have been untravelled. Those 3 untravelled cases, at least the early couple of them, led to investigation of whether it might be endemic in the country. And it does appear to be strong evidence that it's endemic in the New Forest and Thetford Forest, and PCR evidence in ticks in the Thetford Forest. It's very likely to be present in other parts of the country as well. So one of the untravelled people, when I say untravelled, abroad, was in Yorkshire. So, although they could have picked it up in other parts of the UK, our increased forestation, wildlife corridors, movement of wildlife means it's very, very unlikely to just stay in those 2 places. As I said, we don't know how it was introduced, but if I had to use a speculative fiver, I'd go for birds rather than the dogs in this case. But however it's been introduced, we now need to be aware of it, have it on our differential lists. We are seeing increasing numbers of flavivirus cases in dogs. So dogs that are seropositive for flaviviruses and have neurological signs and are positive. I say flavivirus because we have Laupingill in the UK already, which is another tick-borne pathogen associated with sheep. I did get a livestock mentioning, but you can't tell the difference between the two from antibody testing, which is the most common means of surveying and surveillance for these viruses. I mean, in some respects, it doesn't matter. I mean, it shows us, clinical presentation's very similar. It shows that more dogs are being exposed. It's another very good reason for good tick control in high-risk dogs. So certainly now, any dog, not just those with travel history, but any dog with neurological signs, especially when it started with a fever, lymphadenopathy, with or without lymphadenopathy, but certainly fever, acute onset, and then progressive neurological signs that can take many forms, we want TBE on our differential diagnosis list. Unfortunately, there isn't a direct treatment, and the disease is often fatal. So, if we can get in there early, like so many of these conditions, if we can give supportive treatment, so fluids and symptomatic treatment for the neurological signs, it may be possible to nurse the dog through it. But, if we're going to do that, we have to go into it preparing pet owners for the possibility, very significant possibility, that the dog might not make it. Unfortunately, diagnosis is difficult, so you can attempt to isolate the virus from blood or from CSF, but the most common way is with serology, which, like I say, can't confirm TBE, but you can find out if you've got a flavivirus as a likely cause of the neurological signs. Rhiphocephalus is a tick that loves warm, humid, not the UK kind of temperatures. It would need to get a lot warmer here, I think, before Rhiphocephalus started to survive consistently outdoors from year to year. We might get ticks overwintering if it continues to get warm, but not, I don't think, on a consistent basis for a little while. Rhiphocephalus does persist and breed in the UK because it loves our central heating. It means that central heating allows it to persist over the winter, and it can complete its life cycle very quickly. It's very flexible. Larvae, nymphs, adults will all feed on almost anything that moves. And you can see in that situation, I mean, not only do you open yourself up to a potential horrific infestation if you don't spot these ticks and deal with them, but there is the potential for zoonotic bacterial transmission, rickettsial disease, if the ticks are allowed to establish in the home. So, again, identifying them, removing them, having good tick prevention in place is really important. But if they're seen in the home as well, then, getting pest control in, trying to get on top of that quickly is vital. Rhiphocephalus can transmit wide range of pathogens, and they are generally associated with broadly the same type of signs. So if we have dogs coming in and they are exhibiting these signs, we would immediately think of Rhiphocephalus tick-borne infections as a possible cause. So anemia, thrombocytopenia, Babesia vogeli, which one of the large Babesias would be on our differential list, Ehrlichia canis, very common cause of these signs, and Anaplasma platys, which can cause a cyclic thrombocytopenia that comes and goes. All of these parasites commonly cause lymphadenopathy and pyrexia. And they can also cause neurological signs, especially Ehrlichia canis can cause a range of neurological signs. So, these will want to be on our differential lists. It's really important that if we have relevant signs that we diagnose them quickly, again, because if Ehrlichia establishes in the body and becomes chronic, if disease then develops, it is much more difficult to treat with a poorer prognosis. So again, diagnosis, really important for our patients and for patient management. We can do a blood smear in clinical cases, really good for Babesias and also for Hepatozoon canis. Highly specific, but it has a limited sensitivity. We can do serology for Ehrlichia. In those situations, if we initially do a qualitative test, it's useful to go on and do space quantitative tests to see if it's active infection rather than historical exposure. Also, we can do a similar test for anaplasma. PCR with tick-borne pathogens really comes into its own. So Ehrlichia, Babesia, and it also allows speciation with Babesias, anaplasma and Hepatozoon. It's a highly sensitive, highly specific test. Really useful that you've got the confidence that you've got a positive result, but also be fairly confident with a PCR that you've got active infection. And you want to consider these pathogens as differentials in untravelled dogs, but also we do need to bear in mind, that there have been untravelled cases in the UK of Ehrlichia and across northern central Europe, Hepatozoon as well. So although the Rhiphocephalus vector isn't endemic in the UK, I would still consider these pathogens as differentials if I have relevant clinical signs, even if there isn't a history of travel. Babesia canis got some notoriety because of the outbreak in Harlow, which makes me feel old. It's about 10 years ago now, when there was all the sort of excitement and media flare up over the fact that this exotic parasite had established. Dermacenta is its vector, and Dermacenta does have stable UK foci. Those foci are in the southwest of England, southeast of England and Wales. I think if you practice in those areas, you'll probably be familiar with where they are. Compared with a fairly rapid spread of Dermacenta ticks across Europe, especially pushing up into northern Europe, edge of Scandinavia, they remain remarkably stable, these pockets of endemic foci in the UK, although another recent paper did show not dramatic movement, but some movement locally in Essex, it moving away from what were pretty tight foci in Essex. So, there is potential for spread, just not very fast spread at the moment. But that doesn't mean that we should be complacent. At the moment, the outbreak that occurred in the Harlow Dermacenta ticks appears to have died out, and now they can't find any Babesia in those ticks in Harlow. But positive ticks do crop up as these ticks are surveyed in the other endemic areas. So there's been a positive one that was found in the southwest, another one that was found in Wales. So all the time, these foci represent the potential for this parasite to come in and establish. As a result, I would consider Babesia canis as a differential for any dog that presents with unexplained regenerative anemia or thrombocytopenia. Very straightforward to diagnose by PCR or by blood film examination. It's good to do both. A blood film will give you immediate diagnosis. PCR will give you species confirmation. And again, early diagnosis, so key, both to prognostic outcomes, but also the risk of the parasite establishing in these Dermacenta foci. Before I move on, I should always just take a moment to appreciate how beautifully decorated Dermacenta is. Always like to think it's made an effort, much more than Ixodes. If you see ticks that are decorated like this, very important to get them into the tick surveillance scheme so we can keep track of where Dermacentor is in the UK. And if you are doing a blood film, it's just to remind you that it's these often paired, but not always, pear-shaped pyroplasms in red blood cells that you're looking for. They're very, very distinctive. So when we're dealing, well, in general, but especially when we're dealing with imported dogs being relocated, it's really important to check them and treat them for ticks. So we want to check that it's not already been treated, that it hasn't got active residual acaricide on board. If not, we want to use something that's got good repellency and kill or rapid kill. And there are, many different products that fill that brief. But I think that, we're probably in dogs, we're probably likely looking at pyrethroids or isoxazolines. In cats, there's only one licensed pyrethroid that's safe, that's flumethrin. In Seresto, other pyrethroids should be avoided. A wide range of isoxazolines, also now got Tigolana, which is in a closely related but different group. So, lots of good options. For ticks, fipronil on its own isn't going to cut the mustard. It's going to kill some ticks, but not as much. Technology, drug efficacy for ticks has moved on. No product, though, is 100% effective. So even if they've been treated, even if you treat them, pets arriving in the country should be checked for ticks and any found sent to the tick surveillance scheme. So I'm going to spend a little bit of time now considering our friend Leishmania infantum, which over the past, I'm going to say 20 years, certainly, especially over the last decade, we've seen a massive spike of cases in the UK. Some of them measured and reported, again, a massive underestimate of the total. And in terms of SCAT national queries, Leishmania always tops the pile, and they're almost always new or recent cases. Transmitted by sandflies, so that does limit its distribution in the world and in Europe. So southern European parasite, but now seasonally present in Eastern Europe. And again, this is because climate is allowing that sandflies that can transmit Leishmania out of their cage a little bit, and you're seeing increasing distribution. But its distribution is largely limited by the sandfly vector. What we need to remember, though, when we're dealing with imported dogs and when we've got excited rescue organisations or new owners telling us that we just don't need to worry about transmission because we don't have the sandflies, that transmission can absolutely occur in the absence of the vector. And there are parts of countries in sort of northern, central Europe, in Canada, where there has been limited focal endemicity, largely through breeding, has been allowed to occur, even though there's no vector present. So traditional transmission is through phlebotomine, sandfly vectors. They can occur other ways. So vertical, venereal transmission, breeding colonies of dogs. This method of transmission is very common. Blood transfusion, we have to be very aware it can be transmitted by blood transfusion. Less concrete evidence around dog bites and direct contact, although there was a very interesting case, this published in 2023, that was a non-travel dog that appeared to get Leishmania from his infected housemate by licking its open sores. So, and that isn't a unique case. Well, I think the exact method of transmission might be unique, but there are other dogs living with Leishmania dogs that have become infected. So I think these are sort of reasonable routes of infection that we need to be aware of, that we need to be cautious with. If we get enough density of infected dogs, there is the possibility that it may jump vectors as well. This has happened for other trypanosomes like Trypanosoma vivax, which is a trypanosome of cattle. It jumped from tsetse flies in Africa to Culicoides midges in South America, so not unprecedented. Again, we don't want to be complacent as to these risks. Early diagnosis, again, so important for management of leishmania and making decisions as to next steps. But also, if you have in other dogs, particularly immune compromised dogs in the household, we just want to be very, very aware about that potential transmission. And also, we don't want to use dogs for breeding. So, if we know dogs are positive, if they're not neutered, we can prevent them or advise that they're not bred from. Typical signs that we're looking for, as well as screening, can be cutaneous or visceral. So you can get lunettes, these lovely hairless rings around the eyes. Very commonly get hyperkeratosis of the pads, thickening of the nails. You can get ulcers and dermatological changes. Epistaxis is not uncommon. There was one survey that found about 12% of leishmania positive dogs get epistaxis, and without thrombocytopenia. So we don't know why, but it should just flag some alarm bells if you've got an epistaxis dog. But also you can get thrombocytopenia with leishmania cases as well. Polyarthritis is a classic presentation. You also get ocular inclusion bodies, uveitis, but the one that is the killer that shortens lifespan, and it is, well, in the end, it is an inevitability if dogs are infected for long enough, is immune complexes gathering in the kidney and causing glomerulonephritis. And that's one of the unfortunate outcomes of leishmania infection. And you can get neurological signs because of granulomas, CNS. So we need to bear in mind with leishmania that signs can develop months or years after travel. And this is true of Ehrlichia heartworm as well. So something that we need to bear in mind, but it can be a really long time. I've seen cases manifest many years after travel. So that travel history might be lost, but also we're seeing more and more untraveled cases in the UK. I would always have it, if you've got relevant clinical signs, as a differential. Quantitative serology is the mainstay of diagnosis, really useful. So yes, it only demonstrates exposure, but we don't have the sandfly vector to expose dogs in the UK. So if you have high or climbing titers, especially after 3, 6, 9 months, you can be pretty confident you've got an infection. You can also do PCR. You can do it on blood. It carries a relatively low sensitivity. Conjunctival swabs are useful. They're not useful if you've got a low middling titer and you're looking for confirmation, because the sensitivity of conjunctival swabs seems to be correlated with serology. So, it's a good confirmation you've got reasonably high serology, or you're going to use it as a dedicated test, but not so good in those dogs with low titers. You're looking to do more tests. PCR is excellent on lymph node samples, and if you want to get more invasive, on bone marrow aspirates. You can do the same with fine needle aspirates or biopsies, but you can also use biopsies or fine needle aspirates of clinically infected areas like skin or lymph nodes to look for the parasite itself. You can see these little double stained amastigotes here, very, very distinctive. You can either stain and have a look yourself, or you can send samples to an external lab. People get very concerned about the zoonotic risk. Leishmania is a very significant zoonosis but without the sandfly vector, you've actually got to work quite hard to get yourself infected. So there haven't been any, to my knowledge, I'm happy to be corrected, but I'm not aware of any leishmania infantum cases in people that were immune competent that weren't in vector endemic countries, or where vectors could be demonstrated. But it can theoretically happen through open wounds, if you have open sores or trauma, potentially through contaminated needles. I have unfortunately had a couple of colleagues that have accidentally stabbed themselves with blood draws from leishmania positive dogs. They were fine, but it's not something that I would actively encourage. But if you're immune competent, then risk is going to be very, very low. And that's true for pet owners as well. So I wouldn't, if they're worried about keeping and treating their leishmania positive pets, zoonotic risk wouldn't be top of my list of concerns unless they were severely immune compromised people in the household. So control fly repellency is really important in cats and dogs traveling abroad. So in dogs, you've got deltamethrin collar, you have flumethrin collar, which has a variable license, I believe currently not licensed in this country, but is licensed in some countries. It's the only safe product to protect cats, so we definitely want to use it in cats. There are also permethrin spot-ons for dogs with varying fly repellency licenses, but that is the mainstay of protection while cats and dogs are abroad. There are vaccines for dogs. Unfortunately, they're not currently available in the UK, so that's going to be a watch this space. There are sensible precautions you can take. So some flies are poor flyers, so you can sleep at altitude to fox them, find a nice windy location for your tent. You can use insecticide impregnated bed nets. You need to be cautious with those, particularly with cats, and they need to be fine mesh. None of those measures are a replacement for using fly repellency in endemic countries. Just going to briefly mention Brucella canis, even though it's not a proper parasite. It's sort of come into the whole imported dog pathogen story. Surveillance for it across Europe is somewhat patchy. There's strong evidence to suggest that it's highly endemic in Eastern Europe, parts of Southern Europe. It may well be present in other parts of Europe. Lots of dogs are subclinical carriers, but it can cause reproductive signs and non-reproductive signs as well, such as uveitis, famously, bizarrely, discospondylitis, lymphadenitis, and a whole range of sort of non-specific clinical signs as well. I think that screening dogs is really important, but not dogs that are high-risk dogs. So those are dogs that you're looking to import, particularly from Eastern Southern Europe, but I think it's a discussion to be had from any part of Europe. And that screening of dogs is important so infection can be managed, and it's best done before importation, so that decision as to whether to import them can be made. It's a reportable infection, so really important, well, a legal requirement to report any positive cases that you get. And there has been there's a lot of worry about potential zoonotic transmission in practice at the moment, and there has been very recent guidance published on that by the government on the link that I have on the screen there. It's a very emotive subject because we can't clear the parasite. It has zoonotic risk, concern about biosecurity. That always raises the question as to whether you should euthanize. Certainly not an automatic decision by any means, and I think that attitudes have moderated a lot over the last sort of 12-18 months. It can be managed by neutering, by minimizing contact with other dogs. The risk to people is low Once dogs are neutered, the risk is incredibly low. So I think if we have immune competent owners, they can take those steps, they're happy to live with a very minimal risk, then dogs can go on and live happy lives. However, if they are very risk averse, or there's immune compromised people in the house, then you're going to have that discussion about euthanasia, and best to have it before you test, so people know, they're informed, and they know what they're getting into. So just a brief recap of screening tests, because screening dogs, and well, mostly dogs, I mean, this is mostly a dog story. It's much harder to screen cats for many of the pathogens that they might carry. They're much less likely to carry a lot of the pathogens that are listed here. But in dogs, for individual health and for biosecurity, screening tests are so important. So for leishmania, we're relying mostly on quantitative serology with the option for PCR, especially in clinical cases, and to back up equivocal results. Heartworm, we're really relying mostly on antigen blood testing and NOTS testing. But Ehrlichia, Canis, Anaplasma, Hepatozoon, and Babesia, PCR is a really good option. And for Brucella canis, we're still relying on combined serology. That only demonstrates exposure, but it's really the best we've got as a reasonably sensitive screen. So all of these, we need to bear in mind that some of them have lag time though. So we would ideally want to test again for leishmania 6 to 9 months after UK entry, heartworm 6 to 9 months after UK entry, and Brucella canis sort of 3 to 6 months after UK entry. So we can see, unless there's urgent need, there is an opportunity to bring that secondary testing together for convenience and to save multiple blood draws. I mean, if finances are very tight, I mean, some ESCAP colleagues will shoot me for saying this, but I mean, if finances are very tight, then as long as it's informed consent, people understand the risks, they take sensible precautions with their dogs, those tests could be delayed rather than doing them twice, and doing leishmania, heartworm, brucella, say 6 months after entry. But you know, that does, particularly with brucella, allow risk of sort of human exposure potentially to roll on. So that's an economic informed decision. Just to remind you that we have the 4 pillars. So this is ESCAP's national advice for how you should approach imported dogs and parasites. So check for ticks, get them identified, treat with praziquantel and ticks on arrival. So the praziquantel, just in case they've got infected in that 1 to 5 compulsory treatment window, do them again within 30 days after arrival. Recognise clinical signs relevant to disease in the countries that they've come from, and screen for leishmania, heartworm, brucella, exotic tick-borne pathogens, and fecal panel is always really useful as well. And ESCAP is a wonderful source of information. So we have the newly launched Guideline 9, which is parasite control in travelling and imported pets. So I would really encourage anybody who's interested to have a look at that. And nationally, we have downloads and fact sheets on imported dogs and imported dog considerations. So thank you very much for listening after the false start. Thank you for hanging in there, and hopefully we've got time for questions.
Indeed, I hope so too. Thanks so much, Ian. A really informative presentation there, injected with humour, as always. Introducing our old friends, the heartworm and the beautiful ticks.
Well, they are beautiful. You know,
where we can.
Beauty is in the eye of the beholder, isn't it?
Absolutely. There is a lot to like. I think there's some things to not like as well, but at least it makes us enthusiastic about seeing them and treating them with the respect they deserve. They've survived for a very long time despite our efforts to eliminate them. So again, thanks for that. Thank you for everybody that's joined us this evening. We have had some questions come in that I will come to shortly. A couple of people have asked about their CPD certificates. So if you just put your details into the question box or into the chat box, the email address that you would like us to send your CPD certificate to, and we'll get those organised in the next few days. So use that facility. If you've got any questions, pop them in the chat now. Ian, we probably have only about 10 minutes left. If we have additional questions, are you happy to stay over a little bit? Is that okay?
Absolutely, absolutely.
Wonderful, thank you. So we go to the questions. The first one that we had in may have been answered as part of the presentation, but I will go back to it anyway. It was asked quite early on, which was around the Dirofilaria. Is the parasite or the vector, which is limited by environmental temperature, asking regarding the difference of immitis and repens distribution in Europe?
Yes, so the vector's quite happy. There are different vectors, and some mosquito vectors are spreading, and that's important for parasites that need more specific mosquito vectors. So some of the viruses transmitted by mosquitoes are spreading, because specific mosquito species are spreading. That isn't the case with heartworm. There are mosquitoes capable of transmitting it all over Europe. But it's the parasite that requires the temperature. So, that's essentially what is keeping heartworm at the moment limited to certain countries. And that isn't the case for Dirofilaria repens. So, the only thing keeping Dirofilaria repens out of the UK is us, essentially.
Okay, I hope that's clarified if it wasn't clear as part of the presentation already. I'm just seeing if we've got any more questions that have come through just yet. So thanks for Ian's time in answering that one. A couple of other points to answer. Well, just from a HORIBA point of view, you saw as part of the initial presentation from us around our PCR testing facility. So we do have tests for a large number of the pathogens that Ian's mentioned. So we have in-house PCR for those. Obviously, around things like the reportable diseases, they have to go to an external reference laboratory, but we are able to help you out with fast in-house PCR testing. So if you'd like to know more about that, you should have contact details for us on your screen. So feel free to get in touch if you'd like a demonstration, more info, or just to know a little bit more about those. What else did we have come up? Just also to reference as well, Ian has kindly done this kind of refresher on exotic parasites for us. He did originally do this webinar, I think it's about 4 years ago now, Ian.
I was going to say it's 2021. That's also making me feel old. Not as old as the Harlow outbreak, but that does make me feel a bit old.
Well, I realised as well as you were going through, and also we had the Brucella outbreak as well, didn't we, at one time, which is going back a little while now. So, yeah, it's time does march on, doesn't it?
Yeah, absolutely. But the parasites are still here, so
they're still here, still evolving, and it's interesting. 4 years sometimes seems like a long time, and sometimes not. But things obviously have moved on. The encephalitis is something that I don't think we mentioned quite so much last time.
No, that's certainly developed over the last few years. But also the leishmania situation is becoming more concerning. The number of untraveled cases that are being flagged, suggests that either those risks are being unquantified or they're being missed. And aside from UK biosecurity, that's just a tragedy for the individual dogs that are being infected. So, just simple precautions we can take to try and minimise that risk.
Absolutely. I know that we spoke last time as well around the requirement for testing or not, testing, treating of dogs coming into the UK. If I understand and recall correctly, there was a consultation around that, government consultation, but not much came of it.
Well, I think it's still being considered,
Okay.
hopefully in darkened Westminster rooms. I don't know, but it is difficult in, government's defence, in that, if you're going to make testing a legal requirement or treatment a legal requirement, there have to be very definite aims and outcomes in doing that. I mean, it's no secret that I'd like to see Brucella testing made compulsory. But, there would have to be the sort of frameworks and infrastructure around that. It would have to be enforced. So I think winning hearts and minds is as important. Raising awareness is as important, probably more important than legislation, I think.
Indeed, and of course, as we know, there will always be the animals that come in via routes that they shouldn't do, the less legal routes. And of course, migratory birds, etc., will never be subject to any legislation that we try and put in place. There's always a workaround.
No. But in terms of illegal movements and sort of minimum ages and breeding animals, the welfare bill that's currently going through Parliament hopefully will finally land those, and I think those will make a very big practical difference if that can be signed into law.
Okay, that's really interesting. Thanks for that. Just going back to the questions now. We've got, is there the potential for any of the tick-borne diseases to be transmitted from the infected to the naive dog by fleas?
Well, so when we say any, that is quite a broad church. Not the sort of ones that I've covered today. Bartonella, some species of Bartonella potentially we think could be transmitted by fleas and ticks. So I wouldn't say that there's no crossover, but it is surprisingly distinct what fleas transmit and what ticks transmit. So, they are sort of two separate issues. But if there was any overlap, then Bartonella species might be it.
Okay.
Off the top of my head, just think of another one. But, again, someone might leap in and enlighten us.
No, interesting one. And also, just to touch on another webinar that we had recently was around blood transfusions, which was by one of the nurses from the transfusion service from the RVC. She was talking about blood transfusion transmission of pathogens. So, another situation where screening is super key as well.
Yes, is really important. Yeah, absolutely.
Yeah, not so much a question, maybe a comment. We had compulsory tick treatment before importation of dogs in the past, before the EU stopped it. Could we get it back now?
It's unlikely. I think is the answer to that. I think the one thing that we really need to keep is the compulsory tapeworm treatment. I mean, it's very likely that without it, we would already have Echinococcus multilocularis in the UK, and we don't want that. The tick treatment has a number of issues. So, I mean, we lost it. We didn't lose it for any epidemic. Oh, sorry, something's going to get printed in the background. I don't think, we had it for, it was dropped for any epidemiological reasons. It was political horse trading, essentially. But the scientific argument was, it was to prevent, it was to prevent specifically rhiphocephalus and Mediterranean spotted fever, so Rickettsia canorii, coming into the UK. But it was felt when it was dropped, the argument was, well, firstly, that rhiphocephalus would be very unlikely to establish outdoors in the UK, which is true. And also that tick treatments aren't 100% effective. So it's not a sort of solid wall like, say, praziquantel for Echinococcus. So, so some ticks were still getting through. So on that basis, they argued that it wasn't necessarily required or effective. I mean, tick prevention is so important in pets travelling abroad and for cats and dogs coming into the UK. But I mean, I think it sent the wrong message. I think dropping a compulsory treatment suggests that it's not important, and it is important. But I think, it's another one of those situations where we'd probably be more effective persuading clients that treatment for the whole time they're abroad, not just a treatment before they come back, is really important.
Okay, and bearing in mind appropriate parasite treatments at all times. And again, going back to our previous webinars, attitudes have changed. Now we're looking more at responsible use of medicines, not blanket treatment, and taking a much more evidence-based approach to general parasite control, as well as around the time of implementation of exploitation as well.
Yes, and I mean that's important. That is important, and we're fortunate, very fortunate in the UK that we're lacking key parasites that allow us that degree of flexibility. But I think it's important we don't get that message confused with the need to protect, say, a cat or dog that's going to go and spend a few weeks in the Mediterranean, where you've got leishmania, you've got heartworm. Potentially, depending where you are, you've got Echinococcus multilocularis. You've got very, very serious pathogens that aren't endemic in the UK. And I mean, if you go into those areas, then tick protection, heartworm protection, tick prevention, and if you're staying for more than a month and before you come back, Echinococcus prevention are absolutely key. There's potential for very bad things to happen, if you don't have that prevention in place. So, I think it is important to remember that the parasite situation is much more severe in some of the countries that pets might be visiting.
Yeah, indeed. And also, just to go back to the resources that you mentioned as part of the webinar, the SCAP guidelines, which are there for everybody at any time. There's a whole range of information there, which is excellent. Obviously, it's under Ian's control. He's head of SCAP now.
Even if I say so myself, it's excellent. Excellent.
Well, when I do presentations about parasites and control, there's certainly resources that I refer to. We know that they're kept up to date. They're from a very reliable source. Much rather use those than Google, but then Google quite often refer us to those kind of sources anyway. So they're there if you want them. And also just to emphasise as well around the reporting of things. So Ian, as he said before the webinar started, we were talking about keeping your worms or sending them off for identification.
Yes.
And also very kindly identified fleas and ticks for us personally as well. So really useful service.
No, it is important. And, surveillance for parasites that are endemic in the UK as well. So, we may currently, long may we not have heartworm and Echinococcus multilocularis, but we have hydatid, we have Angiostrongylus, we have numerous ticks, fleas with the potential to transmit Bartonella, and, data on where these parasites are, surveillance is so important in helping us to make risk-based decisions here in the UK as well. But if you get a lovely worm, send it in. They want your worms. If you're not going to keep it yourself, then absolutely send it in.
Absolutely. There's a call to action for anybody seeing any parasites that they would like to have identified officially. Then please send them off. Don't keep them to yourself. Spread the love.
Imagine their happy faces when they receive your worm. that should be incentive enough, really.
But there you go. You're keeping somebody in a job and keeping them happy, which both of those are really good.
and helping to maintain UK biosecurity, of course, as well. But absolutely.
So we are drawing to a close now. We haven't had any further questions come in, so now's your last kind of call to action and opportunity to put in any of the questions that you have. I will just take this opportunity to thank my colleagues at HORIBA, everybody from getting the the publicity out about the webinar, the people that do publicise it for us, so people like Vet Times, Vet Surgeon, and in the veterinary CPD groups as well. Thank you to everybody that's joined us, and to the technical team who run the webinar in the background as well. We did have a slight technical hitch at the very beginning of the webinar.
What happened there? Yeah, but never mind, we got through it.
Took us all by surprise. The platform that we use have changed their interface very slightly, and it caught us very, very slightly on the hop. But due to a bit of quick technical wizardry, we managed to get back on track again. So thanks to Ian again for everybody that's for giving your presentation, and to everybody that's joined us. If you have any other questions or comments, you can contact the HORIBA team. The details have been on the screen. If you would like a CPD certificate sending out, then make sure you've popped your email address, and we will have your name as part of your registration. So we'll get those emailed out within the next few days. If you want to see any of the HORIBA equipment or have any further questions, we are in attendance at the events that you can see on your screen coming up in 2025, and we'll be continuing to exhibit later in the year. We've had lots of thank yous there, Ian, in the chat. Very informative presentation, really helpful. Lots about the evidence-based medicine, and a really good update. So maybe in another 4 years' time, we'll be seeing where
Let's make it a regular thing. But no, thank you very much. It's been my pleasure. My pleasure.
That's excellent. Thank you again. It's been a pleasure to work with you, Ian, and to everybody that's joined us this evening or watching back. Thanks again, and wish you a very pleasant rest of your day.
Thanks. Take care.
You too. Thanks a lot. Bye-bye.